So let's start with the introduction of the first section. The section is about sperm and egg surroundings, and I'm happy to call the first lecturer, that is Johan Brown, that is going to talk about the standardizing semen analysis.
Thank you, and thank you to the organisers for inviting me here. So, what I'm talking to you about today is a bit about standardizing semen analysis, maybe why that's important, WHO or who in that context, and what next. I have a usual conflict slide there, but it doesn't affect what I'm saying. So, first of all, often I'm speaking in front of sceptical audiences when it's gynecologists and embryologists, but something on why sperm matter and what the latest evidence is, and then through into talking about the different sperm testing available for us. I think we can all agree that when couples come to a clinic, what they want is a healthy live birth. They're not looking at any of the earliest surrogate markers. Unfortunately, for my field of andrology, usually it's the early surrogate markers that have been used to say whether things work or don't work. And I think that's a real challenge for us when we look at the evidence for sperm and what sperm are doing, what sperm selection or diagnostics may affect. So to make my case for sperm, I'm going to start by talking about this paper that was published in 2022. So this is an analysis of data from something called the HabSelect trial that happened in the UK, and that was 16 different centres across private and state healthcare with nearly 3,000 couples randomised. And what we were randomising to was PICSI. So those that don't know, in PICSI, sperm are introduced to a dish with a hyaluronate spot, and all the motile sperm are there swimming, but only some of them stick. And you pick from the sperm that are stuck to hyaluronate. Otherwise, it's like normal ICSI, everything else the same, but you've just got this different picking selection. And when we saw that in the main trial, overall there was no significant difference in live birth. You can see there it's 27.4, 25.2 in the ICSI arm. So some people will be like, yes, a marginal gain, but obviously 5% was the aim to find significant difference. What's maybe a bit more interesting is the miscarriage data. Now, because this was published in the Lancet insisted on the figures per person randomised, but we all know you actually have to be pregnant to get to the stage of having a miscarriage, so I think it's more useful to look at it as a 14% miscarriage rate in PICSI or a 22% miscarriage rate in ICSI in the trial. Now, I'm not going to talk through it in detail today, but when you look at the data, you can go through the data and see fertilization rates slightly lower in PICSI, otherwise all the rates the same through to clinical pregnancy. At the stage where we're seeing a fetal heart, though, the data starts to change. These are all women using their own eggs, so not donor. And in these couples where the woman is using her own eggs, as you go beyond 35, you see the miscarriage rate taking off in ICSI and staying flat in PICSI. So if we look at a 37-year-old, RCT data, 15% miscarriage rate in PICSI, 40% miscarriage rate in ICSI. It's worth noting, these are all cases where there wasn't PGTA, so these are all having embryos that we don't know whether they're euploid or not, but that very dramatic difference. And the only difference in this trial is how we pick sperm. What it also tells us is that the sperm effects are there and substantial for women using their own eggs as they go beyond 35. So many of our trials to date have looked at donor sibling eggs and things like that, and that's young eggs. They don't show you the sperm effect. Sperm is something that disproportionately have an effect on the older lady. What do we have there in the background to tell us anything? Well, the WHO manual is where most people start with their semen analysis. It's worth remembering right at the beginning the data in the manual is all based on couples who are getting pregnant. So it doesn't tell us about couples who aren't, but we have those different sections in there to guide people. Now, in terms of patient advice and what patients are told, they're told about abstinence, checking their ejaculatory frequency before that sample that they're looking at, and we're told to look at it rapidly. I do think in there is something about abstinence most people miss. So abstinence is really bad for sperm. An ejaculate is an on-demand secretion, so that seminal plasma is mainly coming during arousal. Most men will be aroused each evening during their sleep cycle. They will make some seminal plasma. If they don't ejaculate that sits there and goes slightly nasty. The longer you leave those abstinences, you also get incrementally more poor sperm. And so the frequency of ejaculation is always going to affect what we see. And certainly what we see diagnostically is different from treatment. In terms of the key things that changed in this WHO manual, there is a very clear guide that sufficient volume of sample has to be taken. And I'll touch on that in a minute for why CASA doesn't work to at least take these WHO parameters. In terms of motilities, it's 4-part motility that most of you will be used to. And in terms of morphology, it's 4-part morphology. The key thing there is if your lab have to score head, mid-piece, tail, and cytoplasmic droplet defects, you also have a way in quality control of assessing what they are counting. We've just overseen this coming in the UK, and you would be amazed how many people who can agree on this is 4% abnormal are counting totally different things as abnormal. So that 4-part morphology starts to allow us to standardize and get those measures right. And if we are doing, we should get through to something that you can look at against the reference values. But as I said, those are really only telling us about what normal is. And that's perhaps where people get to the additional diagnostics that some are concerned may be add-ons. And I think there's always a question of why we're doing them. Will we change something? And does that change have an evidence base for it? The main ones that are out there are probably sperm DNA quality assays, sperm ploidy assays, and we're also starting to see functional tests emerging on the market. A good example of that I won't really touch on is the CatSper test that has just been launched out of Germany. That is an absolute diagnostic for sperm not having CatSper, not having that function, so they'll always fail in IUI or IVF. But actually, men in that category are quite rare. So DNA quality, DNA frag. I was one of the authors on this paper back in 2012 where we said DNA fragmentation linked to miscarriage, and that certainly saw a huge increase in me seeing patients that have been told your sperm DNA fragmentation is high. This is probably explaining miscarriage. I think it's worth just looking, though, at those graphs there and thinking about it, because some of the tests have no correlation to miscarriage. And that's really very often missed. When people say they've got high DNA damage, usually that causes a rush towards vitamins, but we all know the data for vitamins is poor at best, although it may link to live birth rates. I think there's a real question about which vitamin a patient takes. Some of these have the likely correct ingredients in. Some of them contain nothing that's ever been tested. Some of them apparently increase the volume of your ejaculate, which is potentially worrying, but isn't something that in any way relates to an outcome that we've looked at as relevant. And then finally, we've seen an emergence of people saying your sperm DNA damage is high, let's do an SSR to get better sperm. And I do think that's a strange step before we're trying to look at a patient and say, if we shorten your abstinence, would you have a better sperm DNA damage result? because most men would rather ejaculate every day in a row and have another assessment than have somebody chop into their testicle. And I think there are certain things that there begin to be worrying about how we're escalating the medicine where there may not be evidence. But coming back to that, this paper's a bit old now, and there can be some data added in, but this is sperm DNA fragmentation against outcome. A really good paper that Madeline Van Welle's group published. Now, here you've got going A is your SCSA test, B is Halo, C is Tunnel, D is Comet. And in that sensitivity and specificity, you can see some of them, basically, there's no point in the test. Yet these are being used interchangeably, where evidence may exist for one with miscarriage, but people are being given a different test, and that test result is being used to escalate the level of care. So there is a real complexity in there, and the one thing that WHO are really clear on in the manual is that if you're going to go away and use a test, you must only use your test on the basis of its evidence. And that's stated very, very clearly in there. Don't cross-reference it to a different test that's testing something different in a different way. But stepping back, what is it that makes a sperm? Well, we know most men are producing like 10 to the 12 sperm in their lifetime, and only around 2 of those ever result in a baby. In natural conception, you're looking at something like a 4-kilometre swim. So I think most of us in this room would fail if we were a sperm. I certainly would. But it's not just a 4-kilometre swim. Actually, there's a whole set of other things there. So that sperm has to be put together right. It's got to be doing its homeostatic function right. So oxidative stress has to be right. It has to have the correct signalling for things to switch on at the right times. Yes, we need the DNA packed right. We need the right number of chromosomes there. We need no damage. We also need the centrioles. And those centrioles are really key because they're going to direct that first cell division. They're going to become the centrosome. And one of the key things there is you need to know you've got good centrioles. How do you know that? You know you've got a good sperm tail because it came from those centrioles. So if you've got flagella problems, you're far more likely to have problems with your centrioles and then have a problem with your spindle. But most tests of those things are invasive. Really, we're driven towards trying to select as well, so we need to look at things we can do without damaging a sperm. And we need to think about how the body does it. Because in the body, we're going from 2 times 10 to the 8 in the cervix to about 20 sperm reaching the egg. On that journey, they'll get lots of oxidative stress, although we tend to worry about that in the lab. But their numbers are massively attenuated. And why is that? Well, it's a complex environment. We've got a histological cross-section here on the left. So, it's a complex environment that those sperm are swimming in. They're swimming on the surface. So when we see videos, we tend to think about sperm swimming inside a cave. But this is sperm on a piece of uterine explant, and you can see they're swimming on the surface, interacting with those cilia. So they're seeing a really detailed 3D environment on a surface. And importantly, it's a viscous environment. So on the left, we're seeing a sperm swimming in media like we'd normally look at it. On the right, we're seeing a sperm swimming in mucus. And that's mucus from the female tract at the right viscosity. So the sperm swims totally differently in that environment. And what we know is that although lots of sperm can swim like the one on the left, very few can swim like the sperm on the right. Most don't have that ability to progress in the viscous environment. And even if we're doing IVF, that's going to matter while they try and go through the cumulus. So this hugely attenuates the number of sperm in the tract just by viscosity. But those that can do it get there at the same speed. There's they're not slowed down. Lots are slowed down to a stop, but the ones that can go still maintain their velocity and carry on, so it's very selective. Now, usually people say, well, if it's all about swimming, CASA is the answer. And I think we know it's not because it's been around for so long. But the key thing with CASA is you take very small samples that are non-representative, usually a microliter. That means that you get things like count wrong if you're looking at semen. But also, it just looks at spots. So this little set of dots here, it's just looking at heads. And this is a bit like us measuring the head of a baby and deciding whether it's going to get a Nobel Prize or not. It's a very simple measurement is how a head's moving. You can't tell if one sperm's attached to another. You can't really tell what's happening. So it quite simply doesn't give us the detail. Whoops. What we need is to look at the flagellum. Now, this is some software funded by the UK government that we developed. And what it allows you to do is, on sperm, track what the tail beat is. When you can see what the flagellum's doing, you can tell what metabolism is doing. If you change the environment, you can see what's happening. You can actually tell something about the morphology of the head, because with the whole tail beat there as well, you can run the mathematics that doesn't just tell you the energetics, but tells you how that's modifying what you're seeing. So I think because of that, because as I said, good flagellum knocks on into things like knowing whether your centrioles are okay. This is really the direction that we're going. So if we look at that PIXI data again, there's other data out there now about AI and sperm, picking it for ICSI. And what that says basically is the fastest sperm is best. The one swimming fastest is best. But if you layer the flagellum into those things, you can start to take sperm on a PIXI dish, hopefully you can see the tail beats there, and look and characterize how the different cells are performing. You can get the flagella beats out and start to look at answers, where you can take flagellum, even in a free swimming cell, and correlate it back to these data. I've got reasonable hope from data that is already being generated across a few clinics that you can start to relate these things to our UI outcome and potentially to selecting gender from the basis of which sperm that you pick. So when we think in the body, what we're looking at is the human female tract, taking a lot of sperm and refining them down to the egg and sperm that get together. Hopefully I've convinced you actually viscosity is the thing that's governing what gets there, what governs that process. When we think about semen analysis, we tend to think we're trying to identify that sperm. Is the sperm that could fertilize an egg there? Does the man have that sperm? I think the other thing to remember...
We have 2 more minutes. Huh?
Yeah. Is that we've got this thing where potentially outcomes relate to male health. We know we can find sperm flagella defects that actually link to lung function, that link to other health issues. So the whole canary in the coal mine thing says maybe we can do more there. You get a poor semen analysis, can you modify your behaviour and actually change the rest of your life or lifespan? So in conclusion, it does make sense that we look at the WHO analysis, modify our practice, and improve the way we do it and standardise. Beyond that, I think most things are still research, and if we're going to apply tests, we do need to think what WHO says about applying them only for their own result. But if you ask me, like Antonio was talking about, for 5 years hence or 10 years hence, I think for sperm, what we'll be doing is using the flagellum and using that to standardise our results, using that as our predictor of what the other things are. And I guess my final message would be, remember if you're seeing patients, that when it comes to those male results, it's the older females where the male factor is going to impinge. It's the older females where any male factor is going to be a problem. Thank you.
Thank you, Dr. Brown, for the interesting lecture. There are some questions from the audience?
At the end.
Oh, at the end?
The discussion will be.
Okay, so,
The discussion will be at the end of the section. Yeah.
so let's, you go.
Okay. So it's a great pleasure to have here the second speaker, Dr. Alessio Paffoni from Como Hospital, and the talk will be causes and possible remedies of failed fertilization.
Thank you, Mariabeatrice.
20 minutes. Thank you.
Hope so. Thank you so much. First of all, let me extend a huge thank you to the organizers, and in particular to Giovanni Coticchio. He has always a good reason for making me study up on the topic during my summer vacation, so thank you so much. I have no conflict of interest to declare. Also, I have to declare a high level of stress, high to very high. I will talk about failed fertilization today, meaning the absence of progression of the oocytes to the formation of pronuclei. So I will not focus on abnormal fertilization. This is quite common situation in IVF cycles, which is getting lower in percentages since protocols and instruments and clinics are doing well, but still represent an unneglectable percentage of cycles. And this is a particularly frustrating condition, both for couples and professionals, because it's not easy to manage. It has been reported that conventional IVF has a higher risk of total fertilization failure compared to ICSI, and we will understand why in the next slides. And many authors try to develop a prognostic model to understand if a couple has a risk of total fertilization failure, but it's not easy. Some studies identified prognostic factor associated with an increased risk, but it is not a matter of study today. Simply in this example, you can find that female smoking or non-tubal infertility or number of sperm cells can be associated with the risk of failed fertilization. But of utmost importance here is that the number of oocytes that you have inseminated strongly can be related to the fertilization failure. And you see that fertilization failure risk is independent from the number of oocytes only when you inseminate 6 or 7 oocytes. So be sure not to be simply unlucky. Make sure to have a sufficient number of oocytes to be inseminated in order to draw conclusions on fertilization failure. You can only be unlucky that day. Remember that 0 fertilized eggs out of 5 is 0% fertilization, but just due to the statistics, to the confidence interval, you still can see that on the right side of the confidence interval, you have a value that is similar to an expected fertilization rate. So before claiming a diagnosis of constitutive fertilization failure, be sure to have a good number of oocytes to be inseminated and make sure that lab condition and clinical condition are working well. In one word, make your quality control measures, use incubators that are working well, equipment that is well controlled, and train the staff. So the question there is what to do after a total fertilization failure cycle. The first level of answer is simply try again, just trying to have a higher number of oocytes with a better maturity. And several groups propose this strategy as an effective one. And this is just an example. You see that in the second cycle after total fertilization failure, nearly 90% of couples have a successful fertilization with a reasonable chance of success in terms of live birth rate. And it's true that TFF is a negative predictor for future live birth, but you see that still couples have a 50% success rate given a reasonable time of follow-up, compared to 70% of the control group. And this concept of trying to have better oocytes is important. It is stressed in several papers, for example, from the group of Giampiero Palermo, where they say that normal fertilization depends on nuclear and cytoplasmic oocyte maturation. So not always embryologist's fault, but just try to get a better stimulation with better competence of your oocytes. But we have to move a little bit closer into details of biochemical events in fertilization in order to understand other possible reasons for fertilization failure. And in this scheme, you see that the very first phases of fertilization mainly concern natural conception, of course, but a standard IVF, particularly important for us. This phase is the recognition and fusion between gametes. It has been defined an unsolved mystery from a leading scientist, which is Enrica Bianchi, so please don't expect me to solve the question today. Just keep in mind that these very first phases can be divided into acrosome reaction, zona pellucida penetration, sperm-egg binding, and fusion, and then polyspermy block. I decided to start with the zona pellucida, which is, you all well know that it's an extracellular surrounding the oocytes, and several glycoproteins have been described composing it. In humans, of particular interest are ZP1, 2, 3, and 4. They are known because a mutation in these glycoproteins can cause complete infertility. ZP2 has been very well studied. It also has been shown to have a role in blocks polyspermy due to its changing conformation after the recognition of the sperm cell. On the other side, the sperm cells have several proteins on the acrosome that are probably involved in the recognition with the oocyte, and they are generally studied because they are potential targets for immunocontraceptive in male. And the most known is probably acrosin, and for interest today is that acrosin deficiency has been shown to be a causative factor for male infertility, because the recognition cannot be performed properly, and the sperm cannot enter the zona pellucida. Once the zona pellucida is crossed by the sperm, another step is of utmost importance, which is the fusion between the membranes of the oocyte and the sperm cell. And in this case, a key protein has been identified in the ISUMO1, which is a protein that is exposed only after the acrosome reaction. In this picture, you can see what happens in mouse, but it's quite similar in humans. And on the female side, the receptor of ISUMO1 has been identified in Juno. This receptor belongs to the family of folate receptor and has been described in 2014 by Enrica Bianchi in this paper by Nature, and it was called for the first time Juno. So also the recognition of Juno with ISUMO1 has been identified as a possible cause of fertilization failure. And the picture, the puzzle is a little bit more complex, and on the right you can see several proteins that have been recognized as mediators of the recognition and fusion between the two gametes. The most important, most known, and reported also here on the left. Please note that subjects with defective expression of these proteins still can produce gametes that are morphologically perfectly normal, but they cannot give rise to a proper fertilization. In this case, we are quite lucky because a possible remedy exists, which is called ICSI. And let me mention briefly also the opportunity to make rescue ICSI in conventional IVF unfertilized eggs. This can be done early, the same day of ICSI, or more friendly, the day after when you see no signs of fertilization. And if you couple this strategy of late rescue ICSI with freeze-all strategy, you can still have reasonable results for the couple facing total fertilization failure. And this will be discussed in more details on Saturday by Paola Biganon. So let's move to another level of molecular mechanisms. This concerns also ICSI, because we are talking about what happens after the entrance of the sperm cell into the oocyte. and have the pleasure to introduce the main actor, which is PLC-Z, which is a phospholipase C, sperm-specific Z. Its main role is to cause calcium ions rise inside the cell, and it is brought by the sperm cell once it gets inside the ooplasm. And this event is typical. It's species-specific, but quite conserved among species. And calcium rise has a typical oscillations with several events downstream. The most important are depicted in these figures and are released from a metaphase 2 arrest, extrusion of the second polar body, cortical granulars exocytosis, and finally pronuclei formation. So all of these key events are downstream the release of calcium inside the cell. Once again, the same concept, just to stress the fact that it's very important, just to say that any abnormalities or deficiencies in PLC, expression, activity, or location, can lead to oocyte activation or fertilization failure. So activation failure in the oocyte due to abnormal or absent PLC, which is not brought from the sperm inside the cell. So the question here is it possible to restore a defective calcium oscillation inside the cell, since it has been demonstrated that nearly half of the fertilization failure are due to this defective mechanism? The answer is yes, at least experimentally, but also in the clinic. We have three main strategies: mechanical activation, we talked about this last year, which is a modified ICSI, let me say a more vigorous ICSI in order to make more possible the release of calcium from internal storage, or electrical activation, which works very well, but unfortunately it's not always easy to have the instruments in a human IVF lab. Or third and most used is chemical activation. You know that several drugs can be used in order to open calcium channels and make the influx of calcium ions both from outside the cell, I mean from culture media, or from internal storage. The main ones are ethanol, ionomycin, 6-DMAP, promycin, and so on. Do they work? Yes, they work. At least it seems. Let me say that robust evidences still are lacking in terms of efficacy or safety or what else. But even if you take an unselected population of total fertilization failure couples, you can restore a certain potential of fertilization and live birth in this couple, as you see in this meta-analysis with an odds ratio of 3.5 more or less. Several strategies have been proposed. The typical protocol is using a chemical activator during ICSI, maybe ionomycin, which is kept 5 to 10 minutes in contact with the oocyte at the time of ICSI. But for example, a variation of the protocol has been proposed, injecting the cRNA for PLC into the oocyte. In this case, authors aim to have a more physiological oscillation of calcium, since PLC is not brought by the sperm cell, but is produced by the oocyte itself. And it seems to work, even if it's quite distant from the clinical application. And another report is more recent, and is of particular interest, the idea to make the rescue with artificial activation the day after ICSI. So when the sperm cell is already inside the cell, you see on the next morning, no signs of activation, you can try to make the influx of calcium ions and try to restore the fertilization potential. I have no results on this topic, just to mention that it's a quite innovative approach. So once we have identified the central landmark of fertilization in the calcium oscillations, we can ask if restoring it can represent the solution for all of the failure in fertilization. Of course, it's not the case. We have to distinguish between events that are upstream calcium oscillation or calcium release, and they can be solved, at least in part, with artificial activation. But if the problem in the cell is downstream calcium activation, calcium oscillation, so the solution cannot be the introduction of calcium inside the cell. And we are talking about particularly important events that, as mentioned before, like metaphase to progression. And I decided to focus on this specific pathway, which is the inactivation of MPF, which is fundamental in order to allow the cell to progress from metaphase 2 to pronuclei formation. And the cell has two main ways to deactivate MPF. The first one is this side, on the left side, inactivating the protein kinase CDC2, and the other one is degrading cyclin B1. And the role of Wee protein has been described in recent years, and is of particular interest here. Wee2 protein is a protein kinase, which in its role is downstream calcium activation, as you see here in this picture. And it has been shown that the absence of Wee2 is a cause of infertility. It has been first described as Wee1 in the mouse model, and also some families in humans have been described. In this report, you see that for women harboring mutations in Wee2 had a complete infertility due to the absence of fertilization. Nearly 50 oocytes were injected, but no signs of fertilization at all. It has been shown that the injection of cRNA for Wee2 could effectively restore the potential of fertilization with the formation of blastocysts in vitro. Even though this is not the case to be applied in the clinic, it still represents a fantastic opportunity of study. So I tried to summarize briefly the genetic causes of total fertilization failure on the upper side for the male and down for the female counterparts according to the phase where they are involved. So acrosine is UMO1, ZP, Juno, Wee2, there's a problem with the slide, I'm sorry. This part Wee2 is to be moved to the last part of the slide. And on the red arrows, you see that if the problem is with acrosine UMO or in the recognition of fusion, the solution can be ICSI. If the problem is activation, normally due to PLC defective role, the solution can be artificial activation. If the problem is downstream, the calcium oscillation, and the problem can be in Wee2, TL6, or tubulin B8, and so on. And so the solution can be really more tricky, and at the moment only for research purposes. More and more genes have been demonstrated to be involved, and maybe that we will talk about these genes later on this afternoon, and they've been reviewed quite recently in fertility and sterility. Just a few words on the diagnostic possibilities of fertilization failure. We have understand that genetics has a key role in this, so I imagine you just call Antonio Capalbo and ask for a panel of genes involved in total fertilization failure, and quite easily he will say that a problem is in male or female or no genetic problems at fertilization. A more easy approach may be the test of PLC in the human sperm with immunofluorescence. You can understand if the sperm cell has a problem in PLC expression. And this is very important because it can help to divide your population into two groups: calcium-related fertilization failure or calcium-unrelated fertilization failure. And this is important because if you mean to make artificial activation, you can do it only in those patients who can benefit from this treatment. Other tests in vitro have been proposed with the mouse oocyte activation test or directly measuring calcium oscillations using epifluorescence. So this is an algorithm presenting a way to perform, just distinguishing people according to the fact that the infertility is due to PLC or not, and propose artificial activation only if needed due to some issues related to safety and efficacy. I have to skip on this example, which is from the Cornell Medicine Center. They simply proposed a way to do this kind of diagnosis, PLC immunostaining, PLC assay using the mouse oocyte activation test. Just put a human sperm inside one oocyte from mouse and see what happens, and make assisted gamete treatment of artificial activation only in those cases. Of note, when they found a problem in PLC, in the PLC assay, they found also several genes that can be involved, not only PLC itself, but also a series of genes that are PLC related. Now they have to move to the last slide with a summary of clinical applications, clinical options available today. So ICSI or rescue ICSI as a remedy for total fertilization failure in conventional IVF. Repeat ovarian stimulation, trying to have a better competence and a better number of oocytes. Test PLC, and if it's effective, propose artificial activation. What kind of artificial activation? It depends on where you work, what kind of couple you have, what kind of ethical committee, what kind of drug, and so on. We have to discuss. And if nothing works, you can think about donation of eggs or sperm, it depends. Or in the future, maybe we will have new activations destined to the second part, the downstream calcium oscillation or spindle transfer. So I want to thank you with this conclusive remarks that I asked to my friend ChatGPT. I asked for a funny conclusion for the treatment of fertilization failure. She said that it's like trying to assemble a piece of IKEA furniture without instructions. Sometimes it just doesn't come together, no matter how hard you try. Thank you so much. Sorry for the delay.
Thank you, Dr. Paffoni. So let's introduce the next lecturer, that is Christian Ottolini, that is going to talk about early embryo arrest and the chromosome aberration.
Good afternoon, everybody. Thank you, first of all, to the organisers of this really wonderful congress. I know the history that goes behind it is very rich, and it's really an honour to be here. So thank you, Giovanni, for the invitation. I've been asked to speak on a topic which I do know a little bit about for once, which is nice, which is early embryo arrest and chromosome aberration. I do have a conflict of interest. I work for Juno, it's quite obvious there, not the receptor, the genetic testing company as it goes. So I will jump into the presentation. So I think to start, what we need to do is set out really what we do know about embryo arrest and chromosomal abnormalities of the early embryo. If we take the starting point of a normally fertilized zygote, we've heard other people speak today, Professor Pellissier, for instance, showing that really one of the biggest problems in IVF is getting embryos to the blastocyst stage. A lot of embryos arrest in vitro, and it is really one of the biggest problems that we have in the clinic as clinicians, to be able to explain this to our patients. Of those embryos that do reach the blastocyst stage, we basically have two categories. So our knowledge is quite vast now with regards to understanding that there are blastocysts that are competent and there are blastocysts that are not competent. So really at the beginning, when we start with a number of zygotes, we really end up with only a small proportion of embryos that are capable of resulting in a healthy pregnancy. So just to pad this out a little bit more, just put a little bit more background to what we know. This isn't just what we know, that there is a little bit more detail to this. So of the half of the embryos that do reach the blastocyst stage, there is a high incidence of abnormal cleavage. So with the advent of morphokinetics, with time-lapse technology, we've been able to observe that many of the embryos that we have in the laboratory divide in very strange ways, certainly not in the canonical pattern that you would expect them to divide. And there's also a really high variation in blastocyst quality. So those embryos that do reach the blastocyst stage can vary from looking, spectacular, supermodel-like, really down to poor quality blastocysts. talking about the high incidence of aneuploidy, which there is a high incidence of aneuploidy, we really need to think about aneuploidy, and I bang on about this all the time, is that we really need to think about aneuploidy in two separate ways. First of all, we have meiotic aneuploidy. So meiotic aneuploidy is that which is really important to us in the clinic. That's the one that really impacts our success rates and requires careful thought. It's predominantly maternal in origin. It's related to the age of the woman that comes to see us in the clinic, and the incidence is directly related, which we all, I think, know to the age of the woman. In contrast, we have also mitotic errors, and these are errors that occur after the embryo has been generated, so post-zygotically. They affect chromosomes from the mother and the father equally. They are, the frequency is totally independent of age. And in fact, we are starting to see that they are related to abnormalities in cleavage. So we do know a little bit about chromosome aberration and arrest, and embryo arrest, because there does appear to be some sort of contribution with regards to aneuploidy and that which we see in the embryo. This is just a little bit of, as you say in Italy, pubblicità, a little bit of advertising for the papers that we've published in the past. A lot of the knowledge that we have comes from these papers and the work of others. Giovanni's group, for instance, which I think Cristina Lagalla is going to present some really elegant work tomorrow. But we have really gained, I think, our experience from my research group, from these publications and others, which have enabled us to sort of begin to answer the questions that are still unknown. So what is it exactly that we don't know? Well, actually, what we don't know is the whole part of the arrested embryos. We know a lot about embryos that make it to the blastocyst stage, but actually, it's been a really big gap in our knowledge. There's been little bits and bobs that have been done on arrested embryos, but actually a really in-depth analysis of arrested embryos has never been performed. And therefore, we really don't have a sense of how aneuploidy affects the full spectrum of embryos. We've had a really biased opinion or biased look at how things affect, how embryos are affected by these kind of chromosomal abnormalities and what the outcome is. So being asked to present this, this topic by Giovanni actually serendipitously coincided with the acceptance of a work that we have been doing for a very, very long time. So I'm really pleased to say that finally, after almost 10 months of revisions, we have this paper out in press. And I would encourage you, once it is out, to go ahead and read it if you are interested in what I have to say today. But just in summary of the methodologies of what we were able to do here is essentially what we went ahead and did is applied PGT using NGS, low pass NGS, to not only blastocyst embryos in a cohort of patients, but actually all of their embryos, including poor quality blastocysts and arrested embryos. And not only did we do that, but we correlated these results with the observed abnormalities from time lapse. So I think that we all agree that time lapse is really, really important. And putting the two things together have given us a really big insight into really what's driving embryo arrest. So for the rest of the presentation, I'm going to try to present some of the really complex work that we put together, and I hope that by the end of it, I can at least convey some sort of sense of why we feel embryos are arresting in vitro so much. So just to give you an overview of how comprehensive our analysis was, we looked at many embryos, in fact, sort of 600 odd arrested embryos and 600 odd embryos that made it to the blastocyst stage. Interestingly, as my first slide suggested, we have a blastocyst formation rate of almost exactly 50%, which fits consistently with most labs around the world. We also then stratified everything using time-lapse analysis so that we had a full spectrum of embryo development. So not only did we look at embryos that were of high quality that would usually be perhaps biopsied for PGT, but we also biopsied and analyzed embryos that reached the blastocyst stage that might not have otherwise been biopsied, and we also looked at embryos that were arrested. You will note here that we didn't test all of the arrested embryos, but what I can say is that for the vast majority of cases where we did analyze arrested embryos, we analyzed all of them, so it was an unbiased look. It wasn't just selecting arrested embryos. We would select a case and we would analyze all of the embryos from that one case. We then obviously looked at the cleavage patterns as well, which I'll talk about a little bit later. I think it's really important to note here that this is not a commentary on the clinical use of PGT for the diagnosis of putative meiotic and putative mitotic aneuploidies, but we established through our previous work a sort of cutoff where we felt that we could putatively call meiotic errors versus mitotic errors, which is really, really important for our study. So this is just a demonstration and almost a validation of this stratification of meiotic versus mitotic errors, or putative. I should really be using putative meiotic and putative mitotic errors. When we look at the distribution in the different categories of embryos, so if we first look at the putative meiotic errors in embryos that reach the blastocyst stage, we see the expected chromosomes that are disproportionately affected, which is something that is really, really evident across all PGT testing platforms. Interestingly, when we look at arrested embryos, the pattern is different, but you can still see some chromosomes affected disproportionately. Interestingly, this is really similar to what you would expect to see when you're looking at oocytes or zygotes. So we do really feel that we are accurately calling, although not accurately to the level of perhaps clinical use, accurately calling and distinguishing between meiotic and mitotic errors. One last thing on this is that with the meiotic errors, there was, as would be expected, and we just checked this to make sure, there was a huge correlation with meiotic, with maternal age, which is really important to ensure that we were calling them correctly. Conversely, on the putative mitotic errors, you can see that the distribution doesn't disproportionately affect any chromosomes. All chromosomes are affected equally, which is what would be expected and is the general wisdom within the field. There was no significant age association, but I think what you can see here between the putative meiotic errors in the blastocyst versus the arrested embryos is already there's a big difference in the frequency or the total frequency of them. So when looking at these two graphs, I think it's important to note that the numbers are very different in these two graphs, but what we need to consider here is the distribution, the shape of the two graphs. The one thing that I have neglected to say, which I'll point out here, is that we grouped each type of abnormality accordingly to whether an embryo had meiotic errors only or mitotic errors as part of the testing that we did. So we can see here that when you're looking at arrested embryos versus blastocyst embryos, the difference in the distribution of aneuploidies is really significant. So both meiotic and mitotic aneuploidies were in fact enriched in embryos that were arrested, but the effect was very, very, very much stronger for the categories where there was putative mitotic aneuploidy, so these categories here. So striking that the incidence of aneuploidy amongst embryos that arrested was 94% compared to 69% of those that reached the blastocyst stage, so a really, really marked difference. So now we come to a little bit of the novelty of what this is sort of a little bit just reinforcing what we thought we already knew about embryo arrest and aneuploidy. But this is where the power comes of analyzing arrested embryos, in that we can begin to model the chance of embryo arrest when you take into account certain patterns of chromosomal abnormality. And again, what we can see here is, at least compared to euploid embryos, both meiotic, putative meiotic aneuploidy and all categories of embryo containing putative mitotic aneuploidy are significantly more likely to arrest, with, again, disproportionately more likely to arrest those embryos that have a contribution from putative mitotic errors. Also, and interestingly, the number of chromosomes that are affected within the embryo is strongly correlated with the chance of embryo arrest. And this was only able to be done because we had the full spectrum of abnormalities across all embryos, with those that are arrested as well. So now, just flipping a little bit back to more of an embryological side of things, looking at cell divisions and embryo arrest. Again, having the full spectrum of the aneuploidy analysis across all of the embryos, but also the time-lapse analysis, enabled us to identify those embryos which putatively would have started life as normal, so those zygotes which had no meiotic abnormalities or putative meiotic abnormalities, and look at the effect of, in this case, the first meiotic division on the probability of arrest. And we see, if you look at normal cell division, where an embryo moves from 1 to 2 cells, all categories other than moving to 2 cells were significantly associated with embryo arrest. So much so that when we conditioned for a euploid embryo, and the first and the second meiotic divisions were normal, the probability of arrest was only 12% versus 75% when we flipped the coin. So there is a really, really strong association with division and the division patterns of the embryo and arrest when you control for aneuploidy. So now we just want to put these two parts together, so the time lapse and the chromosomal abnormalities. And indeed, there is a really strong association between abnormal cell division and putative mitotic aneuploidy. What must be said here is that there is really no association between abnormal cleavage and meiotic aneuploidy. And to answer this question, we have to go back a little bit to some of the work that we've done previously. And we understand that, and we were able to demonstrate previously, that abnormal cleavage is associated with genome partitioning. So when a cell divides into 2, we expect the chromosomes to go equally into 2 cells. When a cell doesn't go to 2, it's very apparent, at least from our work on single cells in embryos, that the chromosomes are dispersed amongst the daughter cells in an unequal fashion, and therefore we end up with cells with monosomy, we end up with cells with nullosomy, and really gross mitotic errors. So this really is the final key or link to put together that sort of abnormal cell divisions of the early embryo are driving these lethal mitotic aneuploidies. Just because I'm an embryologist and I do like these kind of things, the association with aneuploidy and blastocyst quality is something that we've known for a very, very long time. But essentially, I feel that our work is able to demonstrate that embryo quality is sort of an extension of arrest, in the sense that we have poorer morphological embryos that are enriched for mitotic aneuploidy and indeed meiotic aneuploidy, but certainly mitotic aneuploidy, all the way through. And it seems almost that the arrested stages are a continuation of the poor quality embryos, not only from a type of aneuploidy perspective, but also on the proportion or number of aneuploidies per embryo. So I think the picture is just bigger, as with everything in biology, it's far more complex than simply looking at a single thing that is, a single action that is having a single reaction. So in summary, and I do have to speed up a little bit because I've got a little bit more to present, but in summary, this work that we did was really the first application of PGT and time-lapse on a full series of embryos, which enabled us to demonstrate that aneuploidy is enriched in arrested embryos without doubt. I think now at this point in time we can say with a huge element of certainty that aneuploidy is hugely enriched in arrested embryos. A little bit more extrapolation, but I think it's not difficult to draw this conclusion that the leading cause of IVF embryo arrest appears to be lethal mitotic aneuploidies, which are associated with abnormalities in the early divisions and tend to affect multiple chromosomes simultaneously, like I said, with regards to the genome partitioning. This is a small data point which I really couldn't ignore. It's hidden within the sort of bowels of our publication, but this is the take-home message for me with regards to the work that we have done. If we condition on euploidy, so if we take a group of euploid embryos from the start, so embryos that start life as euploids, and they divide normally through the first 2 cleavage divisions, so meaning that they divide from 1 to 2 to 4 cells. At least in our data set, only 4 out of 161 embryos arrested. So therefore, it's, I think, really, really compelling to suggest that it is these abnormal cleavages that we see in the early embryo that are really driving the arrest due to these gross mitotic errors that we see. Lastly, among the surviving blastocysts, there is a really strong association and pattern for aneuploidy, which, as I said, is an extension. So in conclusion, what is the conclusion here? Well, I think the conclusion is that we have a bottleneck, and the bottleneck seems to be this blastocyst transition, where effectively embryos with gross mitotic abnormalities are being eliminated. And this is creating the great loss in embryos that we see in the laboratory every day. Identifying factors which modulate the risk for these early cleavage events and creating these mitotic errors will help us understand more about the underlying reasons for these abnormalities happening, these cleavage abnormalities happening. And if we can work that out, we really have the potential of significantly improving pregnancy outcomes in IVF. We could double blastocyst formation rates, and this would be hugely important, perhaps not for younger patients, but certainly for older ones. I had to really, I know that I've gone a little bit over, but I really had to extend this a little bit more, not through our work, but through the work of others, and really say that the cleavage blastocyst transition is really probably just the start of the bottleneck. The bottleneck is far longer and bigger with regards to the elimination of aneuploidy. We know that aneuploidies make it through to the blastocyst stage. We actually know that aneuploidies implant, but there is an increasing elimination of aneuploidies even when you look at pregnancy. So, miscarriages, etc., leading cause is aneuploidy. So there is this really long bottleneck, I feel, through to the stage of live birth where we see very, very few chromosomal abnormalities. I think it's really, a colleague of ours, Mina Popovic, has done some really, really fantastic work with extended in vitro culture of blastocysts through to day 12 of development. And her recently presented results at ESHRE and ASRM actually are sort of a continuation of what we've been looking at in our arrested embryo study, in the sense that euploid embryos continue to develop. They continue to develop really well. Actually, embryos with a single trisomy as well are important for, needing to understand maybe the ploidy of an embryo for clinical purposes is really important.
Over time.
2 seconds. However, when we have monosomy and when we have other multiple chromosomal abnormalities, these embryos simply do not grow out, and therefore the embryos seem to be eliminating themselves from pregnancy. So on that point there, and I think this is an area that needs a hell of a lot more investigation, I'd like to thank my team at Juno, especially Antonio, for supporting me to continue this work, even though I've moved, and especially my three main collaborators, Professor Alan Handyside, Michael Summers, who the three of us dreamed this project up almost 7 years ago now, and has finally come to fruition, and we wouldn't have been able to get this work published without Dr. Rajiv, or Professor Rajiv McCoy now, who really helped us with all the analytical work. So thank you very much. I hope that I've been able to convey a little bit of a sense of the work that we've had, and thank you very much. Happy to take any questions.
Thank you so much. So let's do some, in any case, if there are some questions from the audience, we have time for a couple of questions. So please. Yes.
We would like to invite the speakers to reach us.
Should I come to the...
No, the
I can
speakers.
stay.
Just the speakers,
The speakers.
yes. Thanks.
Well, thanks to all the three speakers, of course, but I have a question for Christian Ottolini. Well, Christian, I hope you'll pardon my ignorance, but I was wondering whether there have been studies comparing the frequency of mitotic aneuploidies when embryos are cultured alone or together with other embryos, or in a co-culture system, maybe with some somatic cells.
It's a good question. I'm not aware, but I'm not aware of anything. I think it's actually relatively difficult to discern mitotic errors. Hence why I think we're moving away from, in the clinical realm, looking at mosaicism, because first of all, it seems to have no clinical relevance, but second of all, it's incredibly difficult to discern. I think that is one of the limitations of our study, but with regards to that, we applied our methodology equally across everything. So it was wrong equally across all samples. So the correlations hold true in that sense. To answer your question, I don't know, but if you permit me to maybe draw on it, I think that there are likely to be differences when you look at culture systems, when you look at whether it be co-culture, whether it be different, chemically defined media, whatever it is, whatever the constitution of the media is, there's likely to be differences. I don't know how big or how little, but if it influences the early embryo development and the ability of the embryo to divide, as we said canonically, that 1 to 2 to 4, and not undergo this genome partitioning, I think that almost certainly there will be differences that are notable. It's just understanding what is going to induce that and what is going to prevent that from happening, which we have absolutely no clue about. And I don't know whether co-culture is the answer, to be honest.
Thank you.
Hello.
Thank you, speakers. It was really a very nice session. So I have a question for you. So it was very interesting for me to hear that we have underestimated male factor, probably because we were treating young women with good eggs, with repair mechanism. And now that we are treating older and older women, we may see more of the effect of a paternal side. My question is related to which other mechanisms you believe are involved in this, and isn't it that also the paternal age has increased? It's not only the women that are getting older, but also the males, and this also may explain the effect of a paternal age on embryo quality and pregnancies? Thank you.
So doing them the other way around, paternal age certainly does affect things. There's some really nice data from Australia where they put success rates in female age and male age cohorts, and the kind of effects we see in females in the 30s, you get in the men as you go into the late 40s and through the 50s, you get a very similar curve. So there is a male age effect. There are a series of things at play there, I think. If we look at communities in less developed countries, we have a lot of old men with very young wives and children. And we know that in a lot of models out there drove evolution and drove things with that genetic diversity you get from those old men. What those old men don't have is a lot of older wives with children. And so I think wherever we see something where there's a male problem, be that something due to his age or just generally due to declines in male fertility and other things, younger eggs seem to be able to repair it. Now, that might be sperm DNA damage, it may be other factors, but those younger eggs have all the mechanisms there to do the repair. I think, quite simply, we're overloading the older oocyte with a bad sperm. Now, some people say that means that the older lady should go away and get themselves an 18-year-old man, but obviously in a fertility situation, the only thing we can do is try and tune that sperm up. I think when I first started doing research like this, I'd have sort of said, oh, there's not a lot of point in vitamins, you're just losing time, the woman's getting older, time and that female age is the thing. Now I'm leaning much more towards we've got to do as much as we can to try and get the best sperm we can in those male cases, and thinking it's not just a female factor.
Sorry, I have another question for you, if that's okay. I'm really interested in the HabSelect study and the results there. One thing that I can't really wrap my head around, and maybe you can help me to do so, is that the miscarriage rates for the women sort of in the late 30s, early 40s per pregnancy were even lower than what we might expect in natural conception. Like, are we making things better by using the hyaluronic binding?
I don't think we logistically can be making things better, really, but it would seem like that, I agree. Obviously, in ICSI, you've got a whole level of different selections that we've put in.
Yeah, I'm not saying compared to ICSI, I'm just saying compared to PICSI.
Yeah, but I mean, it's interesting to see. Like I say, it's randomized controlled data, so theoretically it's our best standard of evidence. It is very difficult to explain. I've heard people suggest that, maybe the egg can usually do some other chromosomal corrections on the sperm using similar mechanisms to how we get things like UPD, that maybe it can't as the egg gets older and all kinds of things like that.
I guess the one thing that sort of doesn't click with me is that, unless I've been misled my whole life, most miscarriages, especially in women in their late 30s and early 40s, are chromosomal. So
I think now we know that probably about half of them are, but there's probably...
but it's obviously it increases with age. Sorry to push the point, but it increases with age, and probably when you're younger, it's probably less than half, but when you're older, it's more than half in that middle age. I just, like I said, it just seems to me a little bit implausible, or at least difficult to understand, because you're sort of losing aneuploidy, you're losing maternal aneuploidy, or at least the effect of it, which is interesting in some respects, but difficult to understand.
No, I think it's totally impossible to understand with our current mechanisms that we know.
Okay, so let's take the last question from Nikita, then we will move on for reason of time.
Thank you. Question for Dr. Ottolini. I think we didn't answer the main question, for me at least. Is aneuploidy causing the arresting embryos, or is aneuploidy just the result because embryo arrested for some other reasons?
So
And let me finish
sorry,
the
sorry.
question, please. Because even in the embryos who do not show abnormal division patterns, they might arrest. But the question is why?
They very rarely arrest, actually, if they're euploid, at least from our data set. So that last little nugget of information, perhaps I didn't convey it well enough, but less than 5% of embryos that cleave normally and start life as euploid seem to arrest, at least in a reasonable culture system, it seems. Your question is difficult to prove. What comes first, the chicken or the egg? I think that if we look at our understanding of early embryo development, and it's not my forte, but or at least the sort of molecular elements of it, embryonic genome activation is a critical point, and that sort of happens around the blastocyst cleavage stage, morular blastocyst transition, or at least it's a sliding scale, but sort of that's where it begins to be really evident. And these chromosomal abnormalities that seem to be being eliminated are really gross chromosomal abnormalities. So where one might postulate that so much genetic material is missing that the embryo simply doesn't have the capacity to do the more complex, perform the more complex differentiations that are required for further embryo development. But you are totally right, it's speculation. What's very evident, I think, is that there is an association between the two, and it's very, very strong.
Okay, thank you. So let's move on with the next session.